So the question I have for you is, would you feel comfortable using an AI tool if you couldn't customize it or review its content?
No.
Why or why not?
No, because I know I need to know what is behind that and how it was trained, how many things that it used. A great example of you can garbage in, garbage out.
Hello, everyone, and welcome back to a new year, 2025, on the Immersive Medical Podcast. It is the year of AI, and so that is what we are going to kick the year off with today. We're very pleased to have a repeat guest on the Immersive Medical Podcast, Suzie Kardong-Edgren, Associate Professor at MGH Institute of Health Professions. If you don't remember the last time that we met and talked with Suzie, she's faculty, she's a lecturer, she's a nurse scientist. She is also a fellow at the American Academy of Nursing, a fellow at the Society of Simulation and Healthcare, and she's a CHSE, which is a Certified Health Simulation Educator, I believe. That'll work. And she's a mentor in nurse faculty leadership. And we actually have IMSH, which is the SSH conference, one of the biggest nursing conferences of the year, coming up in just about a week here at the beginning of January. So, Suzie, welcome, and thank you for coming back to talk about AI.
Thank you. This is one of my most favorite, most interesting topics.
Let's just kick it right off. In case there are people here listening who are grasping at AI to learn about it, because you're a nurse, you're an educator, you're faculty in any profession, in any field, and you don't even know what it is, but you know you need to figure it out because the wave is coming. Every single company seems to be feverishly or even impulsively just integrating it. And then you're unsure what you're purchasing, but you know that you need to because there's a lot of power there. There's a lot of benefit. So in case you don't know, I would recommend Google, but also an LLM is what we're talking about when we talk about AI. And a large language model is an LLM. And so really to kind of break it down is that it is an intelligence. It's a scraping of data of like the entire internet. And it can create a human-like text in response, and that can be translated into voice, and so you can hear it, or it can be images. It really has turned ones and zeros into language. And think of this, an LLM, really simplified. Imagine you're texting on your phone and like auto suggestions pop up after you type. An LLM is kind of like an advanced version of that, and it's really fast and it's really in depth and it's supposed to be really precise. It also wants to please you, and so it will make things up to try to acquiesce to your request. The next thing that we're going to talk about after that, because this is going to be a big conversation all year in 2025, and it is the words autonomous or agentic or automatic or super intelligent or intelligent AI. And what is that? So if you hear that word autonomous or agentic or something that has agency or an AI agent, that is something that refers to an AI or an LLM that doesn't have to wait for your instructions. And it can make decisions. So like,
it looks like it's making decisions.
Right. So think of it like maybe the simplest way to do that to create a metaphor here is like think of your vacuum in your house, right? It doesn't do anything until you plug it in, flip on the switch, and walk around the house. But those little iRobot vacuums, they just turn on and clean your house for you, and you don't even have to make a choice, right?
And
you
they'll suck up the cat if it's in the way. So
yeah,
that's
right.
The
and
problem
the new
with
ones.
AI.
Yeah, and the nuances here can pick up your socks as it's going. Okay, so. But in terms of clinical simulation and integration into products that are related to healthcare and touching health-related data, these large language models that can predict text precisely and at scale can make decisions when you're not there, when you haven't told it to. That is what we mean by autonomous or agency or something like that. So, Suzie, tossing the mic to you. And really, this first episode this year was just supposed to be a conversation because we don't have all the answers and we really want to have this conversation. As an expert in education, what are the things that you think of when these
First
new
of all, I
technologies are
think
coming with AI?
it can be lovely. It can be wonderful because with those things, it becomes so tedious. Like if it can help teach and be consistent with teaching clinical skills, those repetitive things that we have to do over and over again, like putting in an IV, like doing a dressing change sterilely, a clean, to learn how to gown and glove, to be able to do a Foley cath. And it can teach you, you just contaminated this, do this instead, put your things here, not there. Those kinds of things, it's lovely for. I don't need spider sense to be able to do those things because there's only really one right way to do it. Having said that, a lot of us will fight over if you're doing Foley casts. Should you put the kit on the bedside table? Should you put it between the patient's legs? If a company makes something so that we have those abilities to make decisions on where to put things, or we can argue with the machine I want to put it here because, and the machine thinks that's cool. Okay. For full-blown scenarios where there are family members in the room and things like this, it can probably make up some of the conversations that might normally occur. It might simulate families to a reasonable degree to start preparing a learner for something like that. But I don't know if that's what what the makers are thinking of right now. So why don't you tell me what you're thinking about,
Yeah.
and then I can
Okay.
tell you what I like or don't like about it.
Well, and you gave some very specific examples just now of like what the end product might look like with an AI in it. I'd like to break it down to the nuts and bolts a little bit. And when you think of, AI driven clinical decision making, or the ability for the AI to tell the student it did a good job, what does that? How does that impact you when you think about implementing that type of AI? And you think about trust or security or compliance, and there is an artificial intelligence that's kind of making those decisions or those judgments or those evaluations. What does that make you think of as an
If
educator?
I'm using it to help students learn patterns of care, patterns of certain things, I think it's a reasonable facsimile of a clinical situation. I don't think there is any way to have these subtle color changes in human being, to have the pupils be changing on a person that's having a stroke, to be able, there's certain things that I think as a nurse, as a healthcare provider, I think you were a paramedic, right?
Yes.
Okay. So you walk up and you the gestalt, instantly, ooh, this person's in serious trouble, or I got time here. You can never duplicate that. I firmly believe in AI. It's not that good. What we want is, I want the holodeck, and we're not at the holodeck yet. This is another step on the way to the holodeck where those things might be possible, but it's good. And I am all for it. I think it'll be wonderful, but I think I have a good idea of what its limitations are going to be.
So let's pretend for a moment that the limitations are lifted. There's been a lot of promises coming down the pipe as I keep up with AI news. Particularly, there's a new terminology coming around, which is artificial superintelligence. That it used to be AGI. Everyone was worried about artificial general intelligence. And that is an AI that can operate as good as any human. And it's really great. But an artificial superintelligence is like alien to us. It's just so good we can't even fathom it. So let's just presume for a moment that the AI can mimic that's called a physiologic engine, what you're describing.
Okay.
Right? And there are already algorithms out there that are open sourced for developers to use. And a lot of simulation systems already use them that make the patient bleed and blood pressure go down. And that algorithm is in, right? Volume down, BP down. And so it's called a physiologic engine. And that also could potentially be applied to things like you were describing, which is the pupils.
Mm-hmm.
Do you believe that the nurse educators or clinical educators out there should have a clear visibility into how simulations and scenarios are built with AI, how these tools are
Yes.
built? And what does meaningful transparency mean to you?
So great question. And I think some of us are going to care, and some of us just want it to work, and we want to be able to get a lot of students through. We have so many nursing students coming through now. And a lot of times we've been funded for the students, but we've been not funded for the faculty. So there is a mismatch, and we are expected to do more and more with less and less. So AI is a wonderful opportunity to help fill that gap. So the question was, help me again.
What does meaningful transparency mean to you? Like, should these companies that are racing towards the revenue that AI potential brings,
Yeah.
what kind of transparency do you think they should be providing you? Because what you just described, which is a nurse that's understaffed, overworked, and has too many other decisions to make, so they
Yes.
just need the system
Yes.
to work. That also means they could adopt or integrate something that doesn't have the
That's right.
transparency and guardrails.
I don't think that, I don't mean, the only reason I'm really aware of this is that because I do research and I had to learn something more about AI. And I know that these models have to be trained. I want to know who you were trained on, what biases were built in, either consciously or subconsciously. Is this going to respond the same way if I have a homeless, disheveled looking person in the bed, as opposed to an Asian person, as opposed to a Native American laying in the bed? They come with a set of beliefs and healthcare beliefs that I need to be asking about as a nurse. I don't know if that has been built into that system. It may look like an Asian, it may look like a Native American, but does it have the background holding knowledge in their head of what they think I'm going to do to it, et cetera, et cetera? There are so many things that you need to know, especially if you're going to be using these avatars, these companies, for doing evaluations. The final evaluation, no matter what, is going to be in the clinical setting, because you just need to see things done there, because no matter what, it's not the same.
Can you
But
drill down on that a little bit? I think a lot of people would argue, or these companies would argue, if you're doing the AI sim at the institution, that is the clinical setting, right? But is that true? So what do you mean that the final evaluation has
it
to be in the
doesn't matter
clinical
what
setting?
I think. AACN, NLN all say for accreditation that the final evaluations, as we're moving to competency-based education, need to be done in the clinical setting.
So like at the hospital in front of a
At
real
the
person?
hospital, at the nursing home, out in the field, in a person's home, in home health, at the hospice center, wherever that is. If those were where the clinical outcomes are supposed to be evaluated for competency as a name your position, yes, then they're supposed to be done in that setting.
Those are
So
all people, what you just described. None of those are an autonomous AI, right?
no,
Every single one of those is a human being, a professional with
yes.
experience and wisdom that are evaluating a human being, making clinical decisions and making sure they're doing a
That's right. With the
competent job.
limitations of the setting around it, do I have everything I need in this person's home to be able to do the care that I need? Do I have everything out in the field that I need to do the care that I need? And the system cannot make that up. I have to be able to think in that
Mm.
situation to be able to use the resources available to me to handle the situation in whatever fashion I can. So it's lovely, and I love the idea. I will use AI, and I will be so thankful AI is there, but I know the limitations. If I'm going to use it for high stakes evaluation, I need to know how it was trained and what those background things are in there and how they put that together.
For
And I
those that
can't.
don't know, can you define high stakes evaluation?
High stakes evaluations are, it's going to have a grade attached to it. It's going to decide whether you go on to the next semester or not. Things like that's pretty high stakes. And
And
a
we don't
lot
want
of
to
us,
leave that decision up to an AI.
I would not. I would not. And as much as that makes more work for me, if I don't want to work, then why am I there? If I want to completely abrogate all my responsibilities and turn it over to a machine, I am sure many companies will allow me to do that these days. And I don't think that's really where we want to go.
In healthcare education, learners need consistent, immersive experiences that mirror real-life challenges without compromising safety. Physiologic AI by VR Patients gives you the ability to deliver realistic simulations using a secure and siloed AI that remains consistent with proprietary guardrails. Unlike other platforms, Physiologic AI ensures that no two patient interactions feel repetitive or artificial, but they remain predictable where it counts. Learners experience dynamic patient interactions, but always within a structured, safe environment that you control. Best of all, Physiologic AI never accesses student or user data. The implementation is designed with precision, so you can focus entirely on the physiology and learning outcomes without concern if your data is at risk. Your IT department will love it. Because everything is deployed asynchronously, your training sessions are available 24/7, allowing learners to practice independently with complete consistency and peace of mind. Physiologic AI. AI you can trust. To create training that is as safe as it is impactful, visit vrpatients.com to learn more. All right, back to the show. I want to ask you a difficult question in terms of that. We talk frequently on this podcast about the impending nursing shortage or frontline. It's really a frontline healthcare worker shortage, not just nurses. It's doctors, it's EVS, it's all of them. I don't want to leave out EMS either. It's all of our frontline healthcare workers. The World Health Organization has published data that by 2030, which used to be 6 years away, is now only 5 years away. Mm-hmm. It's going to be a shortage of, but they use the word shortfall of frontline healthcare workers of 10 million. At the same time, there's a huge cohort of people aging out 65 plus that need care. That crossover is really scary. And so the difficult question I want to ask you is, and I'm going to put on the hat of the, feverish VC-backed, venture capitalist-backed startup who's just trying to solve problems at all costs and costs of revenue, and we got to make it happen, Captain. How do you attack a shortfall of that size if you don't let AI make some decisions, let AI evaluate some people? And the argument to be made is that if you always have to be standing in front of a person toe-to-toe, you're limited. There's a bottleneck because there's a limited number of people. And there's already a shortfall of nurses and not enough butt-in seats at schools. So there's your online school, right? That makes sense. That's, Nightingale. They're all online. And I agree with you, by the way. I agree that it should always be a person. I, as a clinical person, would not feel comfortable taking over patient care, having never interacted with a human to make sure I'm competent. But how do you get there?
So I'm saying that a lot of the teaching that traditionally has taken up our time as educators, the thing where you do the Foley cath 5,000 times with each person, it can be taken over by machines. My focus as an educator will change much more to evaluation. This is awesome and it's horrifying because so many of us come with our own biases. And so if I can successfully get somebody through and get them trained up appropriately through machine learning with these new AI type products, lovely. But when they come to me now, I'm expecting to see certain things and have them be pretty well prepared to go through whatever I've got for them. And then all the biases that we know that can exist in healthcare can come to play yet again. Subconscious bias, known bias against people, against situations, against looks, against you name it, the phobias that we've got, et cetera, and our very strange American culture. But but at that point, there's a lot of protection built in because if somebody's going to fail, usually somebody else is going to be involved in making that decision, not just me. So what I'm saying is I can be focused on that heavy lifting of determining in the final summation, if somebody I think is ready to go out and practice as a name that profession, that AI can do a lot of the work that I would have had to do before. So I say it helps us work smarter and maybe at scale and not as hard as we have been. But this means that I have to be willing and know what it's teaching, how it's teaching, to be able to do and feel comfortable letting that go and moving into where I need to be now, which is really evaluation and giving those subtle extra tips, those subtle extra. And I've thought about this because I knew we were going to be talking about this today. Did any teacher ever tell me about Spidey sense? And the answer is no. When I was in school, nobody mentioned it. And I'm sure you as a paramedic, you got to where, I don't know how long it took you, but my first job, including the time that they stick you in with grower babies in the nursery, in the baby nursery, in an NICU, I had 2 months in there first before you move into the bigger rooms and the much sicker babies. It didn't take but 3 months before I had spider sense. And I could move a cart over, the crash cart over, and they would say, "What are you doing?" And I'd say, "I can't tell you. This baby's going to crash. And I can't see it. I can't, nothing here that I can tell you. I just know it's going to happen." I think that happens for most people if they pay attention to their job. I'm sure it happened for you.
Certainly.
I don't know how you can't teach that with AI that I'm aware of, because we can't describe it. And I know research has been done on this. People can't tell you what it is that is the spider sense.
So there's a human touch you're talking about here that is invaluable.
You can't duplicate that. But if I can talk about it, at least people will know when they're getting those uneasy feelings like something's going to change and I don't know what it is.
I'm trying to remember the moment that it hit for me. I cannot place the moment, but I do remember when I was able to act on that, Spidey sense. It was it was the first life I saved, actually, and it was a young woman who came in through triage at the emergency department, and she had an anaphylactic allergic reaction. She was turning into a lobster. I hadn't seen her yet, and I had like this feeling when I heard it come over the little Vocera. And I just grabbed the epi and I drew it up because I had glanced at the triage note. And when she came around the corner, she was already bright red. So I was able to hand the physician the correct med and dose before the order was in, which is kind of a hard thing in a hospital. A lot of people don't think about that, but like there were also people at the bedside in that exact moment when the doctor was asking for the epi, and the other person on the computer was like, "I can't give you the epi until I get the person registered." It was like, "No, give her the epi." And maybe that's a small instance of Spidey sense.
That's that thing. And so that is why so many people survive a trip to the ER, because you do have that Spidey sense, or they survive a code on the floor because people do know they prevent it before it happens. And that you have to be able to have those discussions. I don't think an AI machine can have that discussion with me.
You described something a little bit ago. You said, I want to know what that's trained on. I want to know what your guardrails are. And I think that in an ideal world, every single AI legacy model creator, so when I say that, I'm saying OpenAI, Google Gemini, Anthropic Claude, Amazon's got an LLM now. There's a Chinese one that's coming out that is barreling in that's called DeepSeek, and it's supposed to be the latest and greatest. And do you think that China is going to tell you what it's trained on, or that any of these proprietary models are going to be revealing exactly what it's trained on? Before this recording, I jumped onto OpenAI's publicly available resources on how they put in guardrails, compliance, and user control, and it's a thumbs up, thumbs down. So when you're on ChatGPT, if you get a response you don't like, you thumbs it down. That is how, and then they train on that. And that is the most information that we have. But even if all of these model creators did publish what their guardrails are, you're not in your simulation, you're not actually paying Google for it, right? The model has been integrated into whatever product you are implementing in your curriculum for simulation. And so how that model is being used is further distilled into a product that is now in your hands. So the chances that the user's going to know, unless that company, that simulation company, it's incumbent upon them to reveal to you what the guardrails are and to be vocal and transparent about that. So, and it's even harder because every single state and school is different. They either use national or state guidelines. The school has their own accreditations. Some worry about NCLEX or HESI. Some don't. And they just teach to competency. Some do both. And they all use their own individual standards. So the question I have for you is, would you feel comfortable using an AI tool if you couldn't customize it or review its content?
No.
Why or why not?
No, because I know I need to know what is behind that and how it was trained, how many things that it used. A great example of you can garbage in, garbage out is when, and they hit it really quickly, when they had the black, George Washington, they had the black this. Google wouldn't stop. I think it was Google wouldn't stop making black every founding father. And it was consciously or subconsciously trained by a person who put their biases into that model. It was up and it embarrassed everybody and it went down really quickly. But having seen that, you can't unsee it. And so I know, and we should know as educators that we want to see that background and know how many of what was used to build this. Who helped you decide what was going to go into these scenarios? How were these patients built? And that one of the things that we're working on now for AACN, I know that NLN is doing the same thing, are really true patient cases. Not just the typical thing where we say this is a 65-year-old male who comes in with blah, blah, blah. What we really want is a whole story and a family and a person with a history that will come out as we're training things so that it's more and more human-like. And it will be human-like, but it will not be human. But we all have those outstanding cases that we know that we will never forget, that could be turned into some really good scenarios. But I don't know if companies are thinking along those lines and thinking about what we're being told and what we're thinking about that we need within the educational industry about what we're trying to train to when we're using mannequins or SPs. So those are
standardized
things
patients. SP.
Yes. If I was a company, I'd be trying to make that as transparent as possible for people.
So, what governance features? When we talk about governance, we're talking about guardrails, compliance, user control, that transparency. What governance features or guardrails would make you more confident in using AI in simulation?
Well, one of the things I think that they're building in, which I think is not helpful, is that you said some people are trying to make the patient swear or something like this. If the patient is not going to act like so many patients we get, I don't think that's good training for students. If somebody's going to clutch their pearls the first time a real patient snaps at them or swears at them, we're not doing anybody any favors. So I think that I might be able to have the brusque meter be able to move up or down as I'm trying to build a scenario or not knowing what's going to happen. But there are times when I think if you want this to be real world, it's going to have to be able to do those things.
You just mentioned something, and in terms of guardrails and compliance, that I think is really fascinating. It is something that I have heard anecdotally and numerous times, which is that a lot of these, the guardrails that are put in place by Google and OpenAI are intended for safety purposes to prevent things like the proliferation of racism or reduction in diversity, equity, and inclusion, and kind of like this AI that is abusive or inappropriate and curses. And we operate as professionals in healthcare in this kind of in-between world where, I mean, when I was in the emergency department, 90% of the people there were having the worst day of their life, and they were not pleased about it. And it was completely understandable that they were upset. And, you know, the gloves are off. They sometimes they say some nasty things. And that's not even the mental health patients. When you have a mental health patient,
that's right.
They have a chemical imbalance in their brain. The gloves have been off since day one.
Right.
And they are definitely not going to say nice things to you. And so the anecdote that I have to share, and maybe people listening to this have experienced it themselves, where because some companies are just using the legacy models, the big OpenAI model, and whatever guardrails come with it, as kind of like, oh, we trust OpenAI and their guardrails, and so we'll just use those. There are limits in user control, and users can't get the avatar to be rude or mean or curse or take swings at the user. So, you know, when we talk about what governance features, guardrails would make you confident using AI, are you saying as a educator that you should be able to make the AI avatar in this situation be rude, be mean, be racist, and then evaluate the nurse student on being an empathetic, competent healthcare worker who guides the conversation back to treatment?
Absolutely. A great example of this would be, I know there's training everybody has to go through. We have to do it every year at MGB, is the
What's HM? What was that acronym you just said?
Oh, it's my hospital, Mass General.
Oh, okay, gotcha.
And I can't remember ever. I shouldn't be saying this. If it's MGH or MGB because they just joined, or
there's lots of acronyms. It's okay.
There's a lot of that. But when we do scenarios where people are upset, and you're supposed to angle your body at a 45-degree angle. We've all been through this training. It's amazing how many people, when they're actually in the situation, forget all of that. They're standing there straight on, arms open, ready to be slugged. And it's just like, you just went through training. We're supposed to do this. And here you are in this situation and you're not doing it. So having maybe an avatar really take a swing at you could maybe help, because it's not going to hurt you, but it may help you remember your training. So I do think that having the ability to up the ante in the training that we get to make it as real as possible, especially if you're simulating the ER, if you're simulating an agitated patient in a hospital room, is important, because that is what's going to happen. And we don't want people to go through this simplified, sweetness and light training and then get out into the real world, which is already happening on so many different levels, and have them not ready for how the real world is going to be and what patients are going to be like. I think it's important.
In real clinical practice, patients don't follow a script. Isn't that the truth? And neither should your simulations. With Physiologic AI by VR Patients, you have the power to create immersive, realistic scenarios where patient avatars respond dynamically to both words and actions. Need a patient to de-escalate after calming dialogue with the nurse, or become combative after a missed step? Physiologic AI listens for context and adjusts behaviors on the fly, reacting exactly how you designed it to. Whether it's an anxious patient, a mental health conflict with inappropriate language, or a routine interaction, you're in control of how the AI adapts and improvises. Like bumpers in the bowling lane, guiding realism without losing control. And because it's all managed by you and deployed asynchronously, that's right, the AI changes behavior the way you decided without a proctor. Every learner gets the same consistent and secure experience. Physiologic AI, realistic, secure, managed by you. To deliver realism that meets your learners where they are, visit vrpatients.com to learn more. All right, let's get back to the show. Let's talk about integration for a moment, because as we continue down this discussion around guardrails, user control, and transparency, there's kind of this blanket term tossed around, which is, does this integrate with my LMS? And then there's marketing terminology used by a lot of these companies, which is fully integrated, completely integrated, fully integrated autonomous VR, fill in the blank, whatever SEO terms will get people to click and be interested. And that is kind of where I get into this idea of impulsivity in terms of AI adoption and integration, because that sounds good. Why wouldn't I want my AI integrated and fully autonomous and maybe we even leave autonomous out of this. Why wouldn't I want my AI fully integrated, just touching everything, connected to everything, so that way it's more powerful, it's stronger, it's more realistic? And I think the answer to maybe why I want to pause at that term, fully integrated, is there's a lot of data in an LMS. There's a lot of data in just whatever simulation platform you're using, because people have to have access, which means you've got to put in people's email addresses and some student information, even if it's just a user and password or more. If it's integrated into the LMS, well, then it's sending information back and forth, and it's going to have access to all kinds of stuff. Or is it? Or is it going to have access to all kinds of stuff? And that's where that transparency and guardrails comes in. So what does integration mean to you when AI starts to enter the conversation?
Well, I will say that I think anybody who's purchased equipment in the last 4 years knows that the IT department, wherever they are, is their best friend. Because a lot of times we don't get to buy anything without having IT right there, because they ask questions that we don't think of and don't ask. And that they're going to be on the make this work end of it when things don't work the way we think they're supposed to work. So I think that there's a huge difference between a freestanding school or a university that is not hooked into a medical system. My place is hooked into a medical system. My computer's so locked down, I can't even tell you. To get into my email, I have to put in a code every time I get into it. So I think that I'm going to have IT sitting right next to me to ask the questions that I don't even know to ask before I buy anything. Because they know what they need to know. And you're right, it's going to take a lot of extra space, a lot of probably extra server space, or it's going to be in the cloud. I don't know how that works. I don't know if we're going to want to record everything that we do, especially if we're going to be using it for high stakes evaluations. We're going to need space for that. So, and it's going to take more and more and more power. So I'll stop.
Would you, so in terms of this crawl, walk, and maybe never run approach to AI implementation, what type of data at your institution or any institution is kind of considered protected? So clearly the student data, student information, we don't want, we want to keep control of, we want to protect. Then there's also patient data and information. In terms of simulation, though, a lot of that stuff is kind of fabricated, right? I mean, we're talking not real scenarios. They're simulations. So is there any crossover in a simulation where there's actual real-world human patient data being used for a medical simulation? And maybe there should be some guardrails there.
I don't know if that happens very often. I think if we're using real patient data, which would be awesome because it would be accurate, that it will be de-identified. I don't think there's any way it can get out without it. But I would love to have patient data to actually drop into a case, because there are things that we forget about. Unless I work in that area all the time and I remember every single lab value that ever occurred that led to X. So
I'm talking simple things like an EKG, or someone takes a picture of lab values of a really interesting patient, and then they end up using it in a simulation.
Yeah, I have no axe to grind with that. I think that's fine as long as it's de-identified.
As long as there's the kicker. As long as it's de-identified.
Mm-hmm.
Do you have any thoughts or questions before, like, in a direction that we should kind of wrap this up
Well, of
with?
course, because I'm sitting here, and unfortunately, we're on tape. I'm going to say, and so when is your big thing coming out?
Oh,
And so,
VR patients. But typically, I keep VR patients separate from the podcast.
uh-huh, I know.
Um,
So, what kinds of things are coming out that we should be expecting to see
in general, in
in
AI,
general in AI? What is
okay.
coming? Because everybody's like, oh, and we kept hearing this January for the next 4 months. Look out! It's going to be amazing. So, what is it, and what's going to be amazing that's coming out that we haven't seen yet?
Now, in general, artificial intelligence last year was all about the chat and using it as an assistant, and chatting with it and making your job a little bit easier.
Yes.
2025 is going to be the year of agency. It's going to be the year where these chats, these AIs, are going to be able to make decisions and even click on your screen. Now, you're going to have to probably pay for that type of thing, but eventually one day, in a couple of years, probably maybe like 2 years, a lot of that stuff will just be native in Google if you want it to.
Mm-hmm.
And so, separate from simulation and just talking about news and what's coming in AI, an example of this might be today. You can go onto ChatGPT and ask it to plan a schedule for you, a vacation, give you suggestions. It'll give you reference links of, oh, go to Tahiti and then, do this and do this excursion and then travel to this location. And you can say, my budget's X amount of dollars and I want to spend 8 days. What do I do? And it'll give you an itinerary and a list and links to make purchases. And it's not actually going to follow through on any of that. And it can't, right?
Mm-hmm.
So all it can really do is help you plan, help you budget. But it's not like you can tell ChatGPT, okay, here's my Visa card number. Now go book it. And that is what an agent will be able to do. And so it's almost like a travel agent, honestly, in this example. But in the world where the AI has agency, you tell it to plan your trip, and then you get an email with confirmations, and your account has been debited. Now, in that world, you have given the AI access to your
Absolutely
accounts.
horrifying. Yes.
And it's a little bit scary, right?
Yes.
But if we distill that backwards, that does mean that giving these AI LLMs the ability to make decisions in a chain and in a loop, where you're like, yeah, I want you to be able to make 4 or 5 decisions without me, pushing a button. And you distill that down into medical simulation or integration into VR and AR, then the idea starts to become around maybe grading and sending those grades back and then making changes to the grade in the LMS and then in a loop, or making the evaluation happen for you, or telling the student autonomously that you did a great job and here's why, and that's the final word without a human.
There are people
it just does it.
Yeah, there are programs. There's research going on right now where that is actually being trained. I know that. And you have to have so many examples of saved videos of learners going through the same scenario and all the broad range of stuff that people will do in scenarios, coupled with the grading criteria sheet that has to account for all of the little things that people will do along the way. And you have to have that matched with a group of people that have agreed upon this is how we're going to score things, which means that you got them all to agree on this is how we're going to score things, to train the AI, to then look at the videos, to then compare those videos to how real people scored them, to be able to do what we were talking about. It's a lot of work. And how you do that as a company without people telling you how you want that done, with the subtleties. And I know nurses, we are a fickle group. And one place may insist that it's this way. Another place may insist that it's that way. How that's going to work out for the person who's trying to please everybody, which is that vendor, it's going to be tough. So having the ability to be able to make subtle changes, to tweak things, is going to be important. And yet I want the AI to be able to provide each student the same same outcomes I want to evaluate,
Yeah.
but with a different patient every time,
Consistency.
so that they can't share information, because if they're going to think it's a male, um, Asian male, it's going to be a white female, different age, but the same disease, but they
Right.
can't figure that out. That's going to be
Yeah.
important, but I'm still getting to the same outcomes that I'm trying to evaluate.
Like
That will be awesome.
consistency in clinical decision making, and variation in your approach or your initial interaction, so that way you it's always new. It always feels new. You also, and then you can't figure out how to win.
Exactly, exactly. And the cool thing for our learners, especially with AI, is that I think they will practice more, because the this generation coming up is more of a more gaming, and they like to beat the system. They like beating the RQI system for CPR, and that's very low stakes. But they don't want the machine telling them that they did anything wrong,
Mm-hmm.
and they want to be good, and they want to hear it, just get through it in the time that they're supposed to, and not have and done everything correctly. And
Yeah.
that's great, except that humans a lot of times are going to slow us down, because
Right.
and that has to be built in too.
And what I'm hearing from you is really the ability to thread the needle here is kind of ideal, where there is a level of autonomy or agency that you have control over.
Yes.
Because in order to relieve the tedious workload, so you can be more effective as an educator, we do need, in an ideal world, the AI to be able to make certain decisions for you that are based within the standards that you have set upon it. So you can trust it's going to be consistent, and it's going to provide you with, we'll call it, the evaluations you need to make quick decisions and get your students to competency quickly.
So as I'm sitting here thinking about what we're saying, I think of there's a whole new role for nurse educators, for paramedic educators, for physician educators, to work with companies to build those kinds of things, because I don't know if you've got the people on board
Mm.
naturally that are going to be able to do that for you. So that being able to go back and forth between the academic world, the for-profit world, that vending world, and being able to work together to be able to produce the best products, I think would be fascinating. And again, a new role, and learning how to work with industry, I think is going to become even more important as we move forward in this kind of thing, in
Was
this kind of business, because there's going to be more AI no matter what, and more of this VR, AR kind of, or screen based, it doesn't matter, coming
Mhm.
forward.
Well, let's reinforce the message that while AI offers exciting opportunities, um, thoughtful adoption that's grounded in security, ethics, and educator empowerment is key. Do you have any final thoughts for everyone as they start to head down this road of how do I do this and how do I do it right?
I'm going to say, don't be afraid, be curious. Be curious and ask lots of questions. And I think it is going to be part of the answer that we need as we get more people coming into nursing, and we are not getting more faculty to help. And sometimes more faculty is really not the answer, because if they don't know what they're doing, there's upgrading of faculty too. So standardized students and helping faculty learn how to deal with different experiences with students could be a wonderful place for vendors to be working too, because the variation in students is every bit as common as a variation within our patients.
Well, thank you very much for being with us here today, Suzie. And I look forward to seeing you at IMSH and having a coffee. And everyone else, if you're there, um, I hope to bump into you. And have a great day and have a wonderful 2025. Thank you. Imagine a training platform that works right out of the box. Whether you're onboarding first-year students or preparing fourth-year learners for advanced scenarios, VR Patients makes that a reality. From practicing lung sounds, ECG rhythm recognition, or med math calculations with pumps and drip sets, because everyone loves that, your students can dive into immersive, practical training right away, helping them make the most of their brand new mixed reality headsets from day one. Educators can easily create custom high-stakes or low-stakes simulations tailored to their curriculum, or they can pre-order ready-to-use scenarios from VR Patient's extensive library. And if you want a personalized touch, co-create simulations with VR Patient's subject matter experts and become an expert yourself with a little hand-holding. Whether you're running simulations on the fundamentals of clinical decision-making or building complex medical scenarios, VR Patients adapts to you. And with physiologic AI natural dialogue assessments, your patient encounters have never been more real. VR Patients, real-life training without real-life consequences. Visit vrpatients.com to learn more.